We will reconvene by asking Dr. Kassouf, I think he just walked out the door. No, there he is, okay, to come and do the presentation on muscle-invasive bladder cancer.
Okay, so Dr. Saad spoke about the non-muscle invasive, what we call superficial bladder cancer, and I'm going to discuss a bit about the management of the muscle invasive component, which roughly occupies approximately 25-30% of the entire bladder cancer population. So a couple of facts. The muscle invasive bladder cancer is actually the aggressive, potentially life-threatening bladder cancer if not treated promptly. It requires early detection, it requires early treatment, and there's a number of options that are available that we're going to go over. So maybe what I'll do is I'll take this. So with regards to the options, the standard for the last, I would say, 3 decades have been what we call a radical cystectomy, removing the bladder. That is one of the standard options when the cancer invades into the muscle of the bladder. And sometimes we give chemotherapy after the surgical procedure, or more and more we're giving it before the surgical procedure. And the reason we're giving it before the surgical procedure is to improve the cure rate from this disease. There's also a growing kind of over the last, I would say, 10 years or so, there's slowly growing number of patients being treated with what I call bladder preservation therapy, trying to preserve the bladder without removing it. And I would say the most common one would be combined chemoradiation. So combined chemotherapy with radiation in order to kill the cancer but avoid removing it, avoid removing the bladder entirely. That works roughly, if you're in well-selected patients, it works in approximately 70%, in a sense, which means that 30 to 40% of the time, you still need to remove the bladder after this kind of treatment, if you don't select them well. The other option of bladder preservation, we'll call it partial cystectomy, which is partial removal of the bladder. And this is done much less commonly. Approximately 3 to 5% of the patient population with muscle-invasive bladder cancer will be able to have this kind of procedure because it doesn't apply to most bladder cancer patient population. You need to have a tumor that's small, a single tumor, a bladder capacity that's large enough that allows taking part of it out. And what's important about the partial cystectomy is you need to also follow the patients for life because bladder cancer can recur in the remaining bladder in the future. So what is a radical cystectomy? So that's, as I said, that's the standard operation. So for a man and for a female, it's a bit different. So for a man, it involves removing the bladder and the prostate. For the female, it involves removing the bladder, part of the vagina, the fallopian tubes, the uterus, the cervix, and the ovaries. Once in a while, in a female that is what we call premenopausal, we try to spare the ovaries, but the routine with postmenopausal female is to remove the ovaries with it. And the other thing we do, whether it's a female or a man, is we remove the lymph nodes around the bladder and make a urinary diversion after that. Next. Next. Sorry? So I put this picture up for a couple of reasons. There's, treatment for bladder cancer could be extensive. And I put this up is because just because a patient is 80 years old doesn't mean that, a patient cannot undergo more aggressive therapy. So what's important to keep in mind is not just the chronological age, but what are the other risk factors, other comorbidities, what is the functional status of this patient? Does that patient have a functional status age of 90 or functional status age of 60? And you can see big extremes as the older patient population comes into your practice. Next. So when you remove the bladder, when you have muscle-invasive bladder cancer, is the patient cured all the time? Unfortunately not. Roughly 60% of the time the patients are cured when you remove the bladder for muscle-invasive disease. and approximately 40% they're not cured and the cancer comes back. This is actually a series from one of the what are called one of the centers of excellence in bladder cancer is University of Southern California, where their 5-year what we call overall survival was 60%. Next. When we looked at that in academic centers in Canada, part of the Canadian Bladder Cancer Network, which is now under the umbrella of Bladder Cancer Canada, is actually, we do pretty well, similar 5-year overall survival when the treatment is done in academic centers across Canada. The lymph node dissection is important. So a wide lymph node dissection sometimes can cure patients in approximately 25% of the time just from the surgical treatment alone. So to go back to the schematic that I showed, so we have that urine going in the bladder. Now, once we remove that bladder completely, we have to divert this urine. So those ureters where the urine is flowing through, the urine has to go somewhere. So we do what we call a diversion. And either the diversion is external to the outside or internal. And we'll talk about the different types of diversion. The diversion requires resecting and using a piece of small bowel, small intestines, to try to use this as a conduit to either exteriorize urine to the outside or in a reservoir. The most common type of diversion in Canada and North America is what we call the ileal conduit diversion, where a piece of bowel is taken and reconfigured, next, where it's exteriorized to the abdominal wall through what we call a stoma, and the urine collects there. And if you look at the end, you see that the cutoff is the fascia, so below it is where the ureters from the kidney, we join them in the piece of bowel, so the urine flows there and goes outside and collects in the bag. That's what we call the ileal conduit. Next. And this is a schematic how it looks like. So the ureters are connected to that piece of bowel, and it exteriorizes to the skin through the stoma. And if you look at it on a patient, it looks like this. The bags are a bit smaller now, but more or less the same. Next. The second type of diversion, what I would say, is used much, much less often in North America and actually across the world, is what we call it's called under continent cutaneous diversion, which is basically one type is the Indiana pouch, where you're making a reservoir of the urine using intestine. So you take a bigger piece of intestine, we make a reservoir, and then we make what we call a channel to go to the skin. Now, this channel gets catheterized every few hours to empty that reservoir. So the patient has to put in a catheter every few hours to empty that reservoir. The reason it's not used often is the complication rate of this is more than the other type of diversions. And there's a 25% risk that we need to reoperate because that channel doesn't work properly. So patients are less enthusiastic about picking that type of diversion. Next. To me, with regards to the continent diversion, trying to avoid the bag, that will be my preferred option, and that's the one that is preferred across, I would say, North America, is what we call is the neobladder. And there's either a Studer or a Hotman, depending on the configuration. But basically, you take a piece of bowel, around 55 centimeter piece of bowel. We configure this. I don't have a pointer here, but we configure this in a reservoir here. That little tube on top is connected to the ureter, so the urine flows in that reservoir, and that reservoir is connected to what we call the urethra. That's where the urine passes to the outside. So as I tell patients, this is great in terms of, you avoid the bag, but nothing beats your native bladder. So meaning that, it's not perfect. 30% of the time you can have leakage at night, 10% of the time you can have leakage during the day, 5 to 10% of the time it may not empty well that you need to catheterize yourself. So it's a perfect solution to avoid having a bag outside, but it never replaces the normal functionality of your own native bladder. It gets close, but never replaces it. And that's just a different way of doing that neobladder. So I talked about, so the partial cystectomy, I mentioned it briefly. Again, only a small minority of patients will qualify for this kind of approach. the advantage, you can avoid the bladder removal completely. The disadvantage, cancer can come back even after 10, 15 years of follow-up. So you have to follow with cystoscopies long term. That's the second type where we try to preserve the bladder. And again, that's in a selected patient population. So not any tumor will qualify for doing what we call chemoradiation. Some tumors qualify, some tumors won't. And the idea with this is in tumors that are small, unifocal, meaning that it's not all over the bladder, not causing obstruction in the kidney, there's no carcinoma in situ component. This kind of patient population will fare reasonably well with this kind of approach, as long as the patient knows that approximately 30% of the time it may not work that way, they need to remove the bladder after. But the other spectrum is, 70% of the time it may work, that you don't need to remove the bladder. So they get chemotherapy, and they get daily radiation therapy 5 times a week for approximately a month. This is where they get the radiation therapy, which we call, that's a linear accelerator. That's where they get their daily treatment. I mean, the treatment itself is a few minutes, not long, but it's on a daily basis for a month, roughly. Now, why do we give chemotherapy with the radiation when we pick that approach? Is because with chemotherapy, it makes the radiation work much better. So your cure rate when you combine the two is better than when you give radiation alone. Next. And this I talked about approximately 30-35% risk of needing to remove the bladder after. Next. So, as you can see, there's a lot of options for muscle-invasive bladder cancer, options that can impact quality of life. So, it's very important to sit down with the patient, discuss pros and cons of each, the consequences of each, the ramifications, and what the next steps will be. And ultimately, the patient has to be comfortable with what kind of approach they want to partake in, because they're directly involved into this. Next. This is what I want to, and hopefully a lot of efforts are being put in trying to increase the number of patients getting treated, actually. Bladder Cancer is doing a lot of work into that, but this is an assessment across the states. If you look at the blue and the purple, these are patients that do not get any curative treatment at all for muscle-invasive bladder cancer. And if you notice, as the age grows, there's a significant number of patients in the states are not getting any curative therapy. Something that should be seriously looked at, because that should not happen. Every patient with bladder cancer, at least most of the patients with bladder cancer, should be able to get some form of curative therapy. Next. So when you look at the trajectory of bladder cancer, and with regards to efforts raising awareness, as we talked about, awareness is very important. The patient usually presents with blood in the urine. So that first step, I can tell you, many patients I see, you tell them, when did you have blood in the urine? They've had blood in the urine for a year, and they never thought to seek a doctor. The alarm bells there, so the awareness from a patient's perspective to actually seek a doctor is important. So blood in the urine is not normal. You need to see a doctor to make sure everything's okay. But that's not enough. That's not just the whole picture. If you go to a family doctor, there are certain situations where patients get treated with antibiotics and antibiotics and antibiotics and antibiotics, but sooner or later they're actually having undiagnosed bladder cancer. So there should be awareness even on the primary care level. So delays can happen at every single step on this bladder cancer trajectory, and it's our job and on different levels to try to shorten these delays through raising awareness on multiple levels. Next. So the future of bladder cancer, number one, as Dr. Fred said, there are certain tumors that they behave what we call indolent, and others are very aggressive from the get-go. We are good, but we're not perfect in identifying which one is which. Ideally, we need to improve our ability to predict and differentiate what we call those pussycats from the tigers. We need to improve detection and surveillance to replace cystoscopy. I mean, whoever's had cystoscopy, it's not a comfortable procedure. it will be great to avoid replacing this test with a completely non-invasive test, such as a biomarker. It has not, there are several biomarkers out there, but none have been good enough to replace cystoscopy at this present time. We need to improve our therapeutic strategies. As I told you, yes, we do radical surgery, we do cure patients, but some patients don't get cured. We need to improve upon what we're doing right now. So if you look at the traditional approach of a surgeon scientist, back 100 years ago, it's applied anatomy, they understand the pathophysiology, do one, teach one, and then you do the surgery. This has changed. Next. This is more into the step between that pathophysiology and the treatment, an increasing role for molecular biology, looking at understanding the nature of the disease, understanding what is aggressive and what's not aggressive. Next. I put this paper not for, it's not meant to kind of take you through it, but to highlight that, you know, bladder cancer science last year has been a great year for bladder cancer. There has been a lot of landmark seminal findings in terms of the understanding the bladder cancer, and a lot of it now we're finding is similar to breast cancer biology, where there's certain types that we know that they will not respond to chemotherapy, and certain types, despite it being very aggressive, they'll respond very well to chemo and surgery. So in the next few years, it will be, you know, an increasing role for molecular profiling. I know you've heard this kind of buzzword over the last 10 years, but I foresee over the next 5-6 years, there will be an increasing role for molecular profiling to really identify the right treatment to the right patient at the right time. Next. So raising awareness is key, and Bladder Cancer Canada has been great in doing that. I mean, I don't know if you had a chance to look at the See Red, See Your Doctor campaign. The annual bladder walks help tremendously. The patient education meeting is not helpful from just whoever's attending here, but, you know, hopefully whoever's here will disseminate some of the information across people who you know. And again, increasing research in bladder cancer is important. It is heavily underfunded. And actually, Bladder Cancer Canada has been playing a key role in Canada to promote this kind of activity. David Gutman was mentioning the Canadian Bladder Cancer Information System, which will be a unique in its nature to capture the practice pattern and outcome of our Canadian population, and I think will provide the necessary platform for research to explode thereafter. Thank you again, and I'm happy to entertain any questions.